Hi, I'm Josh McDonald.
And I'm Randa Materi, and we are Hand Therapy Academy.
Let's talk today a little bit about a relative motion orthosis or a yoke orthosis. It's kind of a big hot topic now. Lots of journal articles coming out about when to use it and its application. So let's talk about some of the common ones that we see and maybe some of the quirky ones that we see that may be a good application for it. So, Miranda, what are some common ones that you see that are kind of the standard when we would go to that as a first choice?
Yeah, I think the most common one I probably see is for an extensor tendon injury or a sagittal band injury. I think those are some go to ones we have. And I think the beauty of the relative motion splint is it really doesn't limit the patient's function that much, right? So they're able to do a lot more than what maybe they would not be able to do if they were in a traditional extensor tendon splint or whatever the type of splint might be. And they seem to be very effective for many different things. So not only extensor tendon, but PIP joint stiffness in either the flexion or extension plane. Um, Anything that you can kind of load the joint a little bit more. How about you? What are you using it for?
I had a couple of patients recently come in where the doctor specifically requested yoke orthosis, which was interesting because it's, I think, becoming much more like commonplace for the doctors. We were educating surgeons on it maybe 6, 7 years ago, saying, "Hey, can we use this for extensor tendon?" And now doctors are asking for it, which is great. I had one patient who had a volar plate rupture after a dorsal dislocation of the PIP joint, and the doctor wanted a yoke orthosis in relative extension so that PIP didn't come to full extension, so that we were protecting that volar plate. And like at the ASHC conference, they talked about, we really need to go into that, full dorsal block, maybe a rings, like an oval 8. But I think that was an interesting option because of lots of function. There was no like soft tissue injuries, so that yoke riding across the volar crease of that joint wasn't a problem, but a really good application of it for that.
Yeah, that's one. I think that's a really good one as well that I don't often think of, right? I'm always thinking about putting them in a dorsal blocking finger splint.
Yeah, yeah. And with the dorsal blocking, I feel like there's so much soft tissue squish on P1 that a lot of times they can kind of plow out of it, and still go into full extension. Full extension's okay, we're finding out, but it doesn't really hold them in that 30. But I think that's a decent option too.
Yeah, definitely. And then I know we're talking about extensor tendons. You can't do it for every single extensor tendon, though, right? So I think that's one thing we need to mention with our audience. There's definitely still a place for a longer splint than the relative motion splint. And when are you not using it for an extensor tendon injury?
Yeah, so our ICAM protocol, the immediate controlled active motion protocol, is for zones 4 through 7. If it is the right combination of digits, so it can be any single digit you can use it for. You can use it if there's two digits, if they're either both central or both lateral, but you can't use it for neighboring digits like index and long or ring and small. You also can't use it if it's three or more because you can't maintain that balance where the injured digit is kept up, things start to tip and tilt. So that's when you would need a longer one. And what's you mentioned sagittal band earlier too. What would be our angle of relative extension for an extensor tendon RMO versus a sagittal band RMO?
Yeah, so for the extensor tendon, I'll do 15 to 20 degrees, usually around that. And then for a sagittal band, I'm doing at least 25 degrees. So it
Yeah.
has to be a bit more than what it would be for just an extensor tendon because you want a little bit more slack on those structures for it to heal.
Yeah. And we just want to avoid the peaks and valleys that happen at the MCP and then in that interjoint space when you make a full fist. So trying to keep that from being that dramatic peak that the sagittal bands end up with tension on them. So
Yeah, and I think these are hard to make right, right? Like I feel like the extensor tendon or the relative motion splints are a little bit tricky. And I think you and I have talked about this before. Like one time I had a patient that came from Josh's office and he had made the splint for this patient and she wanted me to like make it just like Josh made it. And it and she's still been a patient. This has been going on for like 6 years, and she comes into me like 2 times a year for a new yoke splint. But it's just kind of funny because she's like, that original one was the best one.
which is funny because I feel like I could make the same yoke splint on the same patient twice and have two completely different fits. The differential between the PIP and P1 can be dramatic, and the ends like flopping around them just to get it over the PIP joint. I'll have patients. I have one now that the doctor wanted a relative motion to get some extension. It's another use for it. If they have a PIP flexion contracture, you put them in a relative flexion of that digit, and it encourages more extension. EDC pull through, stretch to the volar surfaces. But we're chasing all the skin integrity issues. She comes in with constantly dry, ashy skin, and she gets breakdowns. I mean, she's got rashes all over. And she's like, I just can't wear this thing. It splint is awful. I'm like, I don't think it's the splint, but yes, I'll pad the bejeebers out of it. And I'm putting soft surfaces and I'm rounding everything. So sometimes you just chase your tail on those because it's in
Yeah.
delicate web spaces and volar creases. And yeah,
Yeah, I think they're really a challenging splint to make, actually, despite how easy it probably looks. Um, I just had a patient that was really into 3D printing. So he told me, whenever you want to make one of those, just send me your ring sizes and the differential you want of degrees, and he'll print one for me. So
interesting.
yeah, I'll be interested to try. He printed one for me, and I was like, oh, this is actually pretty cool. So I might be interested in seeing if
Okay.
it works or not.
Do you have the ability to make those, I'll say the edges, soft and graded or rounded?
Yeah, he's doing some type of, I forget the type of like resin or whatever. It's a
Okay.
softer one. So I
Okay.
I don't know. We'll test it and see. It
Yeah.
just kind of,
Yeah.
I was like, well, that might be an interesting concept, especially for the person that comes in twice a year for the exact same splint. If I had her measurements, I could just print off, however many she needed.
Yeah. Yeah. And she could get the same thing.
Yeah.
I typically will make mine out of the Orphicast material, unless it's a larger hand, and then I'll maybe use something like the Aquaplast non-perforated. The perforated edges, you just end up with all these jaggedness in the scallops at the cut of the perforation. So I'll use a non, like an eighth inch. With I don't have to double it over. I can smooth the edges beforehand when it comes out of the hot water. So, but a lot of times I'm making out of the Orphicast. I just feel like that's softer on the patient, and I can shape it pretty well.
Yeah. I like a solid material. It's not easy form. It's more like the prism, but oh, it's Encore. It's Encore.
Okay.
And that's what I've been doing mine out of. But
Okay.
I changed, sometimes we just try something new and you're like, oh, I'll try that again.
Yeah. Yeah. Just out of desperation, let's give this a try.
Yeah.
Yeah. Another diagnosis possibility for it that we're seeing a couple of journal articles out on is using it for a flexor tendon injury. So if you've got one, possibly two digits with the flexor tendon injury, you can put them into that relative flexion, and then they can't get that full extension because they're held down, and so they're still slack on there. It's almost like the hand-based wrist-free protocol from St. John's. It limits that terminal extension of the flexor tendon. Interesting concept. I think it's a little early to be adopting that for a lot of patients just yet, but interesting.
Yeah. I think as like suture materials improve and surgeon techniques, and like the different types of anchors they're using and things like that, now that, maybe that will definitely have a place in the future.
Yeah, and you definitely want to make sure it's the wound bed is clean and clear. I wouldn't do it if it was, zone two right over that P1, and you're putting a yoke orthosis right there, or if there's other neighboring wounds. If you just got to make sure the skin integrity is there and wounds are
Yeah.
stable.
Yeah. And there's probably lots of going to be changes in edema for those. That will be interesting to see how that develops in the next 5 to 10 years.
Yeah, yeah. So when you do a relative motion orthosis, how do you get the patient to understand when they walk out how to put the thing on later? Because it can go on like 5 or 6 different directions. Do you put some marking on it so that they understand how to put it on?
Yeah, I usually put like an arrow or something like saying, "Hey, put this arrow towards your the finger or the nail, whichever one." I think I usually tell them to let me know how they want it, so they'll remember it that way. And
Yeah,
then I always
yeah.
tell them if it doesn't feel right, it's probably on wrong.
I would hope so. Sometimes it's on right and still doesn't feel quite right. if,
Well,
if
that's
I
me too.
if I did a funky job on it, yeah,
Yeah, yeah. Or
yeah.
take a picture.
I love that, using their own phone to take a picture. We'll do videos of how to put it on. I usually like to just to make it standard for myself, so I always remember it because I've taken it off the patient, walked over to my heat gun to shape it, and thought, oh shoot, which one? Because if it's index, middle, and ring, and they're all relatively same in size, there's no big step down for. I have a hard time. So as I'm sliding it partway off when it's cooled and I'm going to go like adjust it, I'll take a Sharpie and draw an arrow that points to the nail, and I'll usually put the arrow at the injured finger, so they know like it's either the injured finger hides the arrow or the injured finger is where the arrow goes. So
That's a good idea.
just like just some point of reference so that when I come back over from the heat gun, I don't look like I'm fumbling around, not remembering which way it goes.
Yeah, that's a good pointer. That's a
Yeah, yeah.
good pro tip.
Yeah, so we've got all kinds of different options for it. There's tons of other options out there. One we didn't even get to yet was Miranda mentioned, I hadn't heard of it, is using it for tennis elbow. That's a new one for me too.
Yeah, so I will do this sometimes, especially if patients can't wear the wrist support. Um, like now pickleball's such a big thing, and I feel like we're seeing more and more, more like tennis elbow. I guess we call it pickleball elbow. And so, and getting those people to stop playing is really not an option. So
Yeah,
I've tried where we just do like a relative motion splint and put their long finger in extension relative to the other digits, and it unloads the forces just a little bit. So when they're grabbing the racket, it's not as painful. So I don't think it's like the silver bullet, but I think it's a good option to provide some. Um, Support to that or
yeah.
some protection to it.
And how much of a differential extension will you use?
I typically do 2025, whatever, is going to be comfortable for them, but usually around
Okay.
2025. I try to get them to 2025. Sometimes that's a little hard to do,
Yeah,
but
yeah. Yeah, sometimes finding that big angle change is hard. You're putting a popsicle stick or a pen or trying to hold them and modify the splint. And then when you're done, you're like, that's only 10 degrees. So that can be challenging.
yeah. And then like the thing too is then you don't want to do too much where their fingers sticking out and it's going to get hit with a ball,
Yeah,
and then they have another injury. So
yeah, yeah. All right, that's awesome. We covered tons of different options for when to use it, maybe some tips and tricks. If you have other ways that you use those splints, let us know. Maybe put them in the comments below, but we'd love to hear some ways that you use a relative motion or splint in your practice.